All right, well, let's go ahead and get started. Hello, everyone, and thank you so much for joining us. The Southeast Mental Health Technology Transfer Center is very pleased to present today's webinar event, addressing client spirituality in the clinic and community, strategies for expanding a continuum of mental health care and sustained recovery. My name is Emily Moore, and I will be moderating today's event. Before beginning, I would like to take a moment to describe the work of our center, as well as a few housekeeping items, and introduce today's speakers. Please note that our work is funded by a grant from the Substance Abuse and Mental Health Services Administration, or SAMHSA. And also, please note that our center, as well as the larger MHTTC network, use affirming, respectful, and recovery-oriented language in all of our activities. We invite you to use the same person-centered language when posting and discussing in the chat today. A little bit about our center. The Southeast Mental Health Technology Transfer Center is located in Atlanta, Georgia, at Emory University's Rollins School of Public Health. We are proud to serve the 8 states in HHS Region 4. Our expertise in public health programs, systems, research, and evaluation provides a unique lens through which we can address mental health priorities. The goal of the Southeast MHTTC is to accelerate the adoption of evidence-based practices and approaches to mental health programs by providing training and technical assistance throughout Region 4. We use a public health approach to build leadership capacity and to provide mental health trainings and resources to providers, agencies, and communities across the Southeast. We encourage you to visit our Southeast MHTTC website, mhttcnetwork.org/southeast, to learn more about our center and upcoming events like this one. A few quick notes before I introduce today's speakers. This event is being recorded and will be posted to our website for on-demand viewing, typically in 72 hours or about 3 days. We encourage you to share your thoughts using the chat feature at the bottom of your screen. Please remember to select Chat with all attendees if you would like to share your thoughts with everyone. We will devote time at the end of this presentation to answer your questions. Please submit your questions using the Q&A feature at the bottom of your screen. We also have allotted time at the end of the event for completion of our SAMHSA required evaluation surveys. We will share a link in the chat, or you can wait to be redirected to the surveys once the webinar has ended. Attendees who are interested may download a certificate of attendance upon completion of that evaluation survey. And if you have any questions after the event, please contact us at info@southeastmhttc.org. I will also put that email address in the chat for your convenience. I'm going to very quickly introduce our 3 presenters for today before turning it right over to them. Joseph Currier, PhD, is Professor of Psychology at University of South Alabama, licensed psychology and clinical supervisor at Vets Recover, a clinical psychologist by training, and his research focuses on moral injury and applied psychology of religion and spirituality. Melissa McKnight is the Director of Community Integration with Vets Recover, a nonprofit organization committed to transforming the culture of care by removing barriers to care, delivering quality integrated healthcare, and building a better community through recovery and connection. Glenn Milstein, PhD, is a licensed clinical psychologist and tenured associate professor of psychology at the City College of New York. He worked for 10 years in psychiatric hospitals, struggling with how to bridge interventions of clinical science to life in the community. I'm going to go ahead and without any further ado, turn it over to our 3 presenters so that they can begin today's presentation. Thank you so much, 3 of you, for being here. Take it away.
Thank you.
Hello, everyone, and thank you for participating in this presentation today. I'm going to go ahead and share my screen to get us started. My team and I are honored to discuss ways to address client spirituality in the clinic and the community by using strategies for expanding a continuum of mental health care and sustained recovery. Again, my name is Melissa McKnight, and I'm the Director of Community Integration at Vets Recover. My co-presenters today are Dr. Joe Currier and Dr. Glenn Milstein, and our team represents 3 organizations who have come together to address and develop strategies that expand mental health care and improve sustained recovery. Our organizations include Vets Recover, the University of South Alabama, and the City College of New York. We are honored to do this work thanks to support of our organizations, as well as generous funding from the Spirituality Mind-Body Institute.
All right. Good afternoon, everybody. Grateful to be here with you. We want to get started by doing a couple poll questions just to kind of take the temperature about people's backgrounds, who are participating in today's training. So um, for fellow psychologists, other mental health professionals, in the webinar, if your background is anything like mine, it's possible that maybe this is like the first or one of the first professional trainings that you've ever done related to addressing issues of spirituality and religion in your careers. So if you'd be so willing, use the chat function and just reflect back on your training histories, your career trajectories. So whether through coursework, supervision, attending workshops, seminars, reading books, or other means, please share if you've had any prior training at all in these topics. And if you haven't had any training, yeah, thank you. Thank you. Some people are already writing in no training. Please just go ahead and write no training, right? And I think it's helpful just to kind of take the temperature. Yep, I'm seeing a lot of no training, no training. Yep. Okay. Good. Good. All right. Yeah. So looks like many people are coming into today's training, maybe a little bit kind of naive, or possibly, a bit green, to these topics, which is what we kind of hope for. And we've really tried to gear this training to really meet you where you're at and provide kind of foundational knowledge and possible strategies that you may incorporate in your work. Second question, is anyone here in the training regularly collaborating with clergy or faith-based persons, leaders, organizations in your clinical practice? And if so, in what ways are you involving clergy and faith-based persons and resources in your work with clients? All right, so I see people are doing some chaplaincy collaboration. No collaboration, no collaboration. Okay, right. Okay, we have a clergy person at the state hospital. Good. Yeah, great. So seems like there's a handful of folks that are already, collaborating, with these faith-based resources. I think that's great. The model that you're going to learn today is kind of a framework to think about how we as mental health professionals can effectively bridge and partner with faith-based leaders and organizations and communities, in the places where we work. All right, we can go ahead and move forward with the training.
Thanks, Dr. Courier. So as Emily introduced, Vets Recover is a nonprofit organization focused on improving the health of service members, veterans, first responders, and their families. And as we get into the training today, I want you guys to focus on how what we are doing through this COPE model, which we will introduce, is enhancing this mission and vision, which we have listed on this slide here. Our agenda is listed on this slide. We will go through the rationale for addressing client spirituality and mental health care. We'll give an overview of the COPE model, which stands for Community Outreach and Professional Engagement. And then we'll spend a lot of time discussing how to put COPE into action, both in the community and in the clinic. And of course, we'll wrap with questions and discussion.
All right, so we're going to go ahead and consider kind of a rationale for why spirituality and religion might kind of be core aspects of mental health care. To do that, I think it's important to define like what we mean by these multidimensional constructs. I'm not going to read every single word on this slide. If folks are interested, in these topics, and have done any readings in these areas, you'll know there are virtually hundreds of definitions of, spirituality and religion. These are a couple of the definitions that really guide our work. So these definitions, come from the Handbook of Positive Psychology of Religion and Spirituality, published by Ward Davis and colleagues. This is an open access resource. So if you're interested in getting a copy of this book, you literally just need to type in the topic on Google and you can download a copy of it. Or if you'd like to gain access to it, you're welcome to email one of us. But what you'll notice here is that there are kind of two key terms in both spirituality and religion. One, both of these constructs that refer to a search. This is a lifelong journey. These are not static entities, right? They're constantly in flux. They're moving. They're changing, right? And that they are both focused on seeking encounters with sacredness, ultimate meaning, and connection, right? And that there are many pathways, to pursuing spirituality. Religion, as we know, is one of the core pathways that people, particularly here in the Southeast, other regions of the country, really throughout the world, pursue spirituality in their lives. Next slide. So why would we want to attend, to clients, spirituality and religion, in our work as mental health professionals? Next slide. Well, the first topic is spirituality and religion, are an ethical imperative, for us mental health professionals. So I'm a licensed psychologist. So, my work is, guided, heavily by, the American Psychological Association. But at this point in time, spirituality, and religion are universally included within the ethics codes, standards of accreditation, and definitions of cultural diversity, intersectionality across our mental health professions. Unfortunately, when we compare the attention we give to religion and spirituality compared to kind of other sources of diversity or intersectionality, we know in our training programs, and oftentimes in our clinical practice, we give less attention to religious and spiritual aspects of people's lives compared to kind of other sources of diversity or identity. So in some ways we can sort of think about, religion and spirituality as sort of being sort of like that second or third cousin that you might see at a family reunion every 10 years. They're part of the family. You may enjoy seeing them, encountering them. You may not have any issues with them, but you're not really kind of considering them all that much in your day-to-day life, as clinicians. Next slide. Another reason why, spirituality and religion matters, for us mental health professionals is that these constructs are highly prevalent in the people that we serve. So this is a table that was published in one of the articles from the psychosocial, the Consortium for Psychosocial Stress, Religion, and Health, at Harvard's Public Health School. And essentially what they're doing, in this consortium is they're tracking different aspects of religiousness or spirituality among different racial ethnic groups kind of over time. And what you can see here on the slide, next slide, is that, across kind of racial ethnic groups, kind of only about 5% or less of kind of the US general population would identify themselves as being neither religious or spiritual in their identity, right? And you can see, kind of looking at some of these other percentages, that large numbers of people, are heavily engaged with congregations or communities. You're going to hear more about this from Dr. Milstein in a second. They often have beliefs, such as life after death or the belief in the existence of God, either a personal or impersonal being, that may provide kind of comfort, strength, as well as possibly create struggle in the midst of mental health challenges. Next slide. And that we know, that these beliefs, practices, relationships, kind of possible community connections, that they are very powerful from a mental health standpoint. Yeah, next slide. So we've now had, virtually half a century of research that has continued to increase in rigor. And we know now, from, virtually hundreds of very, very well designed studies that for many people, involvement in, a faith community or a congregation and other aspects of, spirituality or faith can often provide, tremendous strength and healing, that can prevent the occurrence, of mental health issues emerging in one's life, if they encounter a trauma or other significant event. And that also, can really kind of promote recovery, if someone is contending with depression, anxiety, PTSD, the other types of mental health challenges that we see, right? We also know, from work over the last decade or so, that religion and spirituality can also be a source of pain and struggle for many people. So faced with a trauma, faced with a really serious episode of depression or other mental health challenge, for spiritually oriented people, these experiences of suffering can often kind of challenge their faith or their spirituality in ways that are often associated with decreased rates of recovery and sort of more complicated trajectories of mental health symptoms over time. So we've put, several of, the really important reviews, that have been published in recent years. Be happy to provide these slides for folks. These would be either review articles, or Harold Koenig and colleagues recently published the 3rd edition of their Handbook of Religion and Health. This is a resource that tracks literally every single study that has been conducted on religion and health, over the last decade. So again, why does this matter for us mental health professionals? One, we have an ethical imperative to attend to religion and spirituality as key aspects of diversity. Two, these are highly prevalent. And three, they're highly powerful and operative from a mental health standpoint in the lives of the people that we care for. So I'm going to turn things now over to Dr. Milstein to talk about the COPE model.
Thank you, Dr. Currier. So we have religion and spirituality that has been wherever humans have been. And Joe just went over the different data that we have that speaks to it. And so the questions become how we engage it. And the other thing is to take a moment to give it its astonishment from the perspective that something so influential, we are born with no content of, right? We're born without a single word of whatever language we're going to end up speaking. We're born without a single prayer of whatever religion we may become a part of. And so religion is developmental, just like language is. Religion is also cultural. It comes from within a context. And then it also has personal meaning for folks. So if we're going to engage that resource, we need to be thinking on those levels, think about how to engage on those levels, because part of what we've learned is that if we can do our work to help resolve the clinical presentation that someone has, the key, whether it's substance abuse or mental illness, is going to require that they make it back into community to sustain recovery. So if we're going to do the whole job, we're going to need to be able to sustain recovery. And the best way is to recognize that religion and mental health care are different. We have a border between us, and we can bridge that border, and that's how we'll sustain recovery. And so I want to show you some pictures of that. But first, I want to, next slide, recognize that we have content to religion. That is, there's no such thing as religion, right? There are each person's religions. Go ahead. And go ahead. In the United States, that means 236, go back one, 236 different denominations, which is in many ways 236 different languages, and we don't have 236 different treatments for depression. So it's how we engage to understand that person. This is what Joe was speaking about, as far as our ethical obligation to treat the person who's in front of us. And that requires that we ask certain questions, which Dr. Courier is going to go into. Next slide, please. There are also, across the recognized, there are 574 Indian tribes, which also have at the core a religious understanding. And so to be able to work with Native Americans is also to be able to speak and inquire about the spirituality. So we're, again, speaking to how we treat the person in front of us. Next, please. Now we have the cultural connection, we have the cultural language. But with religion, you also have structural connection. Go ahead. Meaning there are buildings where people go and have gone for thousands of years. This is the King's College Chapel at Cambridge University, which still every day has services, which has a chaplain who also does programming on helping people get along, on mindfulness, and often finds herself making referrals to the mental health center on campus. Next slide. Built over 500 years later, also in Cambridge, is the mosque there. Next click, please. Which also sees itself very much as community serving. So you have many different religious organizations that have, as within their own mission, a desire to help the people and use the resources. Trick is to find clinicians who reach back to them. Next slide, please. So go ahead. There are, in fact, in the United States, over 300,000 congregations. So to think of that from a public health perspective, that's over 300,000 doors we could knock on to try to expand the work we do so that people can go from the clinic into the community, again, to sustain recovery. Go ahead. And to give that more direct way of thinking about it, in West Virginia, which I know is not in the Southeast, but still in West Virginia, you have a congregation for every 420 people. In Alabama, where we've been working, there's a congregation for every 455 people. Pennsylvania, we have colleagues doing a lot of this work. Nevada might be a little bit harder, but you still have a very high concentration of opportunities to get directly to work into communities. Go ahead. So what does that look like? If you could pop into the chat, what do you see in front of you right now? In particular, with the rectangles in the middle, what pattern do you see? Go ahead. It looks like stairs, right? Are they stairs? It's decreasing in size. Bar graph going from high to low. So you have these different sizes. And in fact, what you're looking at is the epidemiology of what I was just talking about, the whole job. So you have a large rectangle. And then you're also seeing that there's increased shading. And what that's representing is greater difficulty, right? Greater challenges that are happening. Next slide, please. Go ahead. So the two rectangles on the left are in one group and the two on the right are in another group. And this is what we're talking about today. These are the two parts that we want to be able to build bridges for. Those who are clinicians are going to be on the right. Go ahead. So the first thing is to recognize that community is where most people spend most of their time. Continue. And sometimes we need clinical care. Go ahead. And so this is the map of community outreach and professional engagement, the map of the big picture. Go ahead. Within community, we have stress. And what happens most of the time is through the support we have in our community, our families, our community, we return to health. The paradigm you can think about through this whole conversation is grief. Bereavement and grief is something that happens to almost everyone. We lose someone and we're debilitated by that process. For most people, it's in community that we get the support necessary to return to health. Go ahead. And always hope is going to be part of what moves us along. When it comes to dysfunction, that is when we need clinical care. And when clinical care works, we are in recovery and we're back in community. Go ahead. What we know about mental illness is it also can be very debilitating to require either intensive care in the community or even inpatient care. And even then, the goal is to get back to community. And so for the clinical, those of us working in clinical settings, to engage with community really requires a more active, go ahead, bridge building. And that's where, go ahead, you get sustained, hold on, you'll get sustained recovery, right? You get sustained recovery when both parts are working together. And that means, in clinicians we've worked with, they find out if the clinic is a resource to the people they work with. And then we do trainings in the community to help them make referrals to us, so that in this way, you really are building a bridge, right, that you can go back and forth on. And in that way, get care as soon as you can and move back into the community. Go ahead. Because the hardest part of what we do also is that harm can happen almost in whatever stage that someone is in. And the more resources we bring to the care, the better it is. And so this is a map of the whole way we look at that. And to take a minute and just focus in on the community part of this, go ahead. You're looking at where clinicians are not. And we need to really acknowledge all that's going on before we ever see anyone, because so much of our training is about assessing a problem and then responding to that problem and resolving the problem, which doesn't yet put us thinking in terms of what is everyday health. Go ahead. So when you talk about well-being, right, which is one of the keys, feeling connected to community, feeling a sense of belonging, in a religious setting, you're going to have life cycle rituals, you're going to have education values and social justice. And as Joe pointed out, the good news and bad news about religion is that it's powerful, which means when you feel denigrated and put down by your religion, it's that much more heavy. And so as clinicians, we also need to assess for when religion is a source of negative feelings. Go ahead. So then for individuals in a setting, you have your own times of hope and celebration. We have our own way of thinking and just getting out of bed and going into the community and having a community there, which is why also they can be a source of shame. Go ahead. And as we've noticed before, you've got a structural place where when you have grief, there's people coming to your home. There's people helping you out. When you're in the hospital, people come and visit the hospital. Again, it can be very negative if you feel like you've been ostracized or been no longer welcome. Go ahead. And sometimes part of the job of the clinician is to explore with the person if they feel that there's a different congregation that could be more welcoming, a different setting. And so very specifically, there are faith practices to someone's own background. There's counsel that comes. And all of this together is happening when there are clinicians. And I really wanted to flesh out the different kinds of resources that are everyday occurrences that we want to think in terms of from a public health perspective. Please note that all the vocabulary here is in really talking about resources at a cultural level in a structural place that we can make contact with. Go ahead. So I hand it off now.
All right. So with that COPE framework in mind, we want to spend, a bit of time kind of sharing, some of the lessons that we've learned around kind of applying, this conceptual framework both in the clinic, and then Melissa in a moment will talk about kind of some of the different strategies that we've developed and learned, in terms of, implementing COPE in the community, right? So with kind of that broad, conceptual framework in mind, we have these two lines of effort, for us mental health professionals. The first, is what we call inReach. And this really captures kind of trying to kind of use COPE, to enhance, the effectiveness and the responsiveness of our services for addressing and honoring, our clients, spirituality and possible faith systems. Right. So how do we do this? Well, here on the slide, we have 5 of the strategies, that we've developed, over the last kind of 3 or 4 years, in our Vets Recover, outpatient clinic, which is an interdisciplinary integrated behavioral health clinic that we provide evidence-based psychotherapy, counseling, primary care, and peer support. We're certified by the Alabama Department of Mental Health, and we've received funding from SAMHSA as well, for our clinic. So I think, the first step, for the clinic is doing kind of a bit of a self-study, self-evaluation, ideally led by leaders, administrators, to really kind of introspect and determine, do our organizational and clinical procedures, really make room and honor the possible strengths and struggles that faith and spirituality can provide, right? And then on the basis of that, that's kind of self-study, kind of introspective work, then possibly modifying, organizational clinical procedures as needed. So in a minute, we'll talk about, ensuring that you're capturing or making room for issues of faith or spirituality in assessment, right? If you determine, similar to today, like, wow, many of our clinicians, they have never had any professional training in these topics, right? So one of the possible limitations when it comes to spirituality and religion compared to other issues or aspects of diversity is that many of us, we might be people of faith ourselves, right? So we might have personal importance of faith or spirituality, right? And we may draw more on our personal background than our professional training, right? And as mental health professionals, we need to assure that we're meeting certain competencies and we're working within our professional scope of practice. Yes, our personal backgrounds can help us, they can aid us, right? But we don't want that to be the basis for our professional competence, right? So there might be a need for training, right? Very simply, you want to make sure about some of those bi-directional kind of collaborative kind of processes in a minute, attempting to collaborate with chaplaincy, community clergy, other faith leaders in the same way that you're collaborating possibly with other healthcare professionals. So referring for kind of other healthcare services that your clinic may not be able to meet or your practice may not be able to meet, referring to other community resources, right? We want to make room for those faith-based resources to be kind of part of our expanded frame of reference where we're involving those resources in care as well. And then ultimately, using routine outcome monitoring, other procedures to track, not just the spiritual, I should say the psychological outcomes of care, but in those cases where spirituality is really important to your clients, you might want to be, including some measures of spirituality, in the treatment process. Next slide. Right. So for those of you who have not had any training in this topic at all, maybe, you're not necessarily personally religious or spiritual, right? You might be wondering, like, well, what does this look like? Like, what are the standards or the bar that I need to set for myself? Well, the slide here kind of outlines kind of 6 kind of emerging professional practice guidelines that a task force that was commissioned by Division 36 of American Psychological Association has identified. So both Dr. Milsey and I have the privilege of serving on this task force. And what you can see here is kind of using, our traditional kind of tripartite model of awareness, knowledge, and skills. In terms of awareness, if you look at number 2, like, we would hope for that every mental health professional is self-aware about how your own spiritual religious background kind of may influence the way that you react or respond, to your patients, right? So, we want, folks to be self-aware about how their own spiritual religious backgrounds is possibly going to influence your practice at times, right? Um, you know, in this way, be aware of your bias, right? And be able to, care for all peoples effectively, regardless of their, yeah, exactly, spiritual diversity, working with spiritually diverse groups. In terms of knowledge, looking at numbers 1 and 3 and 4, right? That ideally, like, all mental health professionals are going to have at least rudimentary or basic knowledge about kind of different key ways that faith or spirituality can both kind of promote health and recovery, and also ways that sometimes, spirituality and religion might diminish health and recovery and maybe interfere with your treatment goals, right? So you might need to kind of expand your frame of reference to really think about aspects of spiritual struggle or spiritual distress in the same way that you're attending to kind of various indices of psychological distress. And then from a skill standpoint, looking at numbers 5 and 6, I think, number 5, that ideally, like, we would like all mental health professionals, to have the comfort and the capability of inquiring about spiritual religious aspects of people's lives in the same way that you're discussing other aspects of cultural identity or diversity, right? And then in cases when spirituality or faith is really, really important, ideally from an ethical standpoint, we need to stay in our scope of practice. And ideally, we need to have the willingness to consult and collaborate with clergy, other spiritual care professionals, or qualified colleagues, or other individuals when appropriate. Next slide. So kind of focusing particularly on, the one basic skill that we lay out in the guidelines, that we would hope that everybody here who's on this webinar will begin to routinely inquire about your client's spirituality and faith, right? So thinking about, what, like how do we cope? We bring it into the clinic. The first practical way is that, that clinicians, are routinely inquiring about people's spirituality and religion in the same way that they're ideally inquiring about issues of race, gender identity, sexual orientation, all of the aspects of diversity, intersectionality that really matter, right? And that really kind of define kind of how we experience the world and move through the world, right? So ideally, step 1, you're going to have the comfort and the skills to broach the topic of spirituality and religion with your clients, right? In cases when, there is cultural or clinical relevance, ideally, you're going to have the capacity to respond skillfully in those moments, drawing on your clinical skills, your empathy, your cultural humility, right? In the same way that you're going to be using those clinical skills to attend to other aspects of your clients' lives. And then, we know from research that, that roughly, 1 out of 2 clients, particularly those, who are highly spiritually oriented, might place great importance to their faith, they may want to include their faith or their spirituality in the evidence-based treatment that you might be doing, right? So, if you're working with someone who is severely depressed and they're in a major depressive episode and you're doing behavior activation, right? Maybe you want to be kind of like focusing on doing some so in vivo exposures or interventions to get that person kind of attending services again, or back in a small group, or kind of reclaiming some of the territory of their lives that they may have, kind of given up or shrunken away from as a result of their depression, right? So kind of using our clinical skills, our clinical interventions, to address spiritual content and aspects of people's lives. So that's kind of what we're getting at here for number 3. Next slide. All right. So how would you start a conversation, right? So these are a set of 5 questions that we piloted, over a year or 2 in our outpatient clinic. We include these questions in our intake questionnaire. And then we've also trained our clinicians, to ask these questions, in the initial intake session or like early on in treatment, right? So, ideally, we would hope that every clinician in our clinic, like they have these questions memorized. You're meeting someone for the very first time, having the willingness to ask them, well, do you view yourself as a religious, and or a spiritual person, right? If someone says no, you may not need to go any further, right? But if someone says yes, you may want to then, prompt, like, well, tell me in what ways, like, what does it mean for you to be religious, or what does it mean for you to be spiritual, right? And then you can kind of work your way down, these other questions. Are you connected with a religious or a spiritual community? Number three, getting at, the possible darker side of religion and spirituality. Has your faith or your spirituality contributed to some of your problems? Have the problems that are bringing you in for treatment affected you spiritually? Four, like getting at that strength resource part of faith, right? Has your faith or your spirituality been a source of strength in your life? And then, when relevant, you want to, ask your clients or offer to your clients, would you like to explore ways of including your faith or your spirituality in your care? And I think one of the key applications of COPE, and Melissa's going to talk about outreach in a second, having the willingness to possibly involve, a faith community or a faith leader from that person's life in the treatment process, that, as you're transitioning out, you're possibly moving toward termination, ideally that person is going to be able to be re-entering a community or deepening connections in a community, right? And then that community can then extend the duration of the support that in that person's life, particularly if they have a chronic condition, or an addiction, that, isn't just going to be a quick, 3 months of treatment, right? Now, I will say one comment. When I have learned, I work with trauma survivors, a lot. In cases when someone may say no, like to any of these questions, like, so looking at number one, do you view yourself as a religious or spiritual person? They may say no. Sometimes it's helpful to then inquire, well, would have you answered this question differently at an earlier point in your life, right? Or, have you had any changes in your spiritual beliefs or practices kind of over the course of your life? And I think what I've learned, both as a practitioner myself and also as a researcher, is that many people who experience trauma, they often have a weakening or an exiting or distancing from faith or spirituality. And that's often associated with more protracted suffering and more severe PTSD and other trauma symptoms, right? So understanding any changes in their spirituality or faith can also enhance your conceptualization and your responsiveness to them. May highlight the need to address the darker side, possible spiritual distress, spiritual struggles in their life. Melissa?
Thank you, Dr. Courier. I will go ahead and walk us through some outreach strategies that we've used to implement COPE in the community. And I want to start by sharing a phrase that our community integration team uses all the time. We know that treatment happens in the clinic, but true healing happens in the community. So while the work of mental health professionals is invaluable, if it's not paired with a supportive community, we know it's incomplete. So we want to build that bi-directional community and clinic connection so we can achieve sustained recovery. With that in mind, here in Mobile and Baldwin counties, we have worked diligently to build up our community assets through various outreach strategies, which I'll go through over the next few slides. First and foremost, we have developed a list of faith leaders and faith-based organizations in our community, and you would be astounded, or maybe not, we are in the Southeast, about how many faith-based organizations are in our area. There are over 300 in Mobile County alone. And these faith leaders, they want to be a part of this team. They feel called to. They feel like they need to attend and support the wellness needs of their congregations. So we started this process by building an asset map, and you see a screenshot of it on this slide. I'll go through it pretty quickly in just a few moments. This asset map includes where these faith-based organizations are physically located, as well as what unmet mental health needs their congregations might be experiencing, and what assets that the faith-based organizations might have to share with their congregations and beyond. This interactive mapping tool helps visualize these needs as well as these assets. So I want to reiterate that this tool is simple, it is replicable, it was free to create, we made it on Google Maps, and it tells a pretty profound story. We've used it to tell our story to funders, we've used it to help figure out where we need to go next in terms of outreach, as well as where to make connections. And our intention is for clinicians to use it as well if they're working with a client in the clinic and they want to connect them to a faith-based organization that perhaps has a food resource. They could use this map in that way. Further, I hope you can see through this map that we are not creating any infrastructure. The infrastructure is there. We are merely acting as a force multiplier as we go out into the community to extend treatment beyond the walls of a clinic. So if you'll pause for a moment, I'll stop sharing this screen and pull up the map to walk through briefly for y'all. Okay, can you give me a thumbs up if you see the map now? Okay. So we are focused in the southwest corner of Alabama. We have both Mobile and Baldwin counties. And what we've created through this map is various layers. We start with the congregations, and you can see there are many, many, many of them. Then we're able to overlay additional faith-based organizations that aren't necessarily congregations, but those who have some sort of faith mission. We also can overlay food resources, those congregations that have a food pantry, for example, congregations that have counseling, housing, and so on and so forth. You can add to the map or subtract layers if the map is starting to get too busy. And then additionally, you can click on each point to learn a little bit more. For example, we have listed a point of contact, a denomination, staffing resources, whether or not this individual faith-based organization offers a warm welcome. This map is constantly under construction as we learn more and add more, and it's a beautiful way for us to continue this work as we extend beyond the walls of a clinic. Going to transition back to our PowerPoint slides now. Hold, please. We also have worked to create educational experiences for our faith-based organizations. So we've used evidence-based training called Mental Health First Aid, as well as spirituality and mental care. We want to offer trainings like this to equip faith leaders in their congregations with skills and tools to recognize individuals who might be experiencing mental health challenges, how to assist them if appropriate, or refer to a professional if that's needed. We want also to show our support for these different faith-based organizations by attending various events that they might be hosting. These pictures are two examples of what we've been doing in the community. The top is a mental health first aid training that we offered at a local church called Mount Zion Primitive Baptist Church. And the bottom is an outreach event, a 3-day event, in fact, that a local church hosted called the Kingdom Covenant Connections. Last but not least, we are working to develop a mutual referral network with our faith leaders in our communities. It's that bi-directional bridge that we've been talking about throughout this entire presentation. We know that the faith-based organization infrastructure is wide-reaching, and by partnering with them, it helps extend our reach into the community. So what we want to build is a strong relationship in which those faith-based organizations feel comfortable referring their congregation to our mental health clinicians and know that those mental health clinicians have experience and training in addressing faith and spirituality. And conversely, our mental health clinicians have that relationship with these faith-based organizations, so they know they can refer them to individual organizations that have the assets to meet these needs. Perhaps they offer a warm welcome or those additional resources such as food pantries, housing, so on and so forth. The screenshot here is an example partner agreement that we have created between our organization, Vets Recover, and the various faith-based organization. It details the partner responsibilities that we said we will do, what we ask the faith-based organizations to do, as well as an opportunity to come up with shared goals together. Lastly, we are building a multi-faith coalition that includes various denominations of faith leaders, so we can come to some shared goals across denominations. We started with an inaugural Building Bridges event, which brought together those faith leaders as well as mental health clinicians, again, to come up with those shared goals for sustained recovery. And we're using that as a stepping stone to something larger. Last but not least, we were recently notified by the Alabama Department of Mental Health that we received funding to continue this work, as well as other community peer support initiatives. So it's lovely to hear that this work is not only valuable, but valued and is being recognized across the state level. So that concludes this portion of the presentation. And Emily, I will be happy to turn it over to you to address any questions.
Wonderful. Thank you so much to the three of you for this excellent presentation. I'm going to go ahead and open it up in the chat and in the Q&A feature for those of you that have any questions for our presenters. I saw that several people were asking about how that absolutely phenomenal map was created. And I saw, Dr. Milstein, you explained a little bit about how the map was created in the chat to answer that question. I was hoping that while we were waiting for some folks to fill in their questions either in the Q&A feature or in the chat, if you could expand on that a little bit, because yeah, I would like to echo what everyone said in the chat, that map is really interesting.
I'm going to defer to Melissa, who really was the person who spearheaded all of this.
Yeah, absolutely. So we started by creating a Google map. So anybody with a Google account can go into Google Maps and create a personalized map. And from there, you literally type in an address and drop a pin into all the different locations that you wish to highlight. You can color code them by selecting different colors and also select them, push them into different layers. So like faith-based organizations, mental health organizations, so on and so forth. And then you're able to go into the back end of Google Maps by merely right-clicking, and it pulls up a Google Sheet. They're all connected, and it allows you to drop in different data points you wish to add. So for example, for the faith-based organizations, we wanted to collect data on point of contact, denomination. You do have to manually go in there and input that information. So we were honored to use the skills of some graduate students in Dr. Courier's class who went in and physically dropped in each of those pins, each of those data points, and we're able to create that robust map.
That's wonderful. Thanks so much for clarifying that. I do see that there's a question in the chat about the slides and a recording. Yes, the slides from today's presentation will be available on our website in about 72 hours time, and there will also be a recording of today's webinar event. And there are no CEU certificates associated with today's training. It is a certificate of attendance for your records. So Thomas, if you look in the chat, I have just dropped an evaluation link. If you fill out that evaluation link, you will be able to download a certificate of attendance for your records after you complete that survey. And again, if there are any questions for today's presenters, please go ahead. You can drop those in the chat or you can drop them in the Q&A feature, whichever is more convenient. I also have put our info at southeastmhttc.org email address into the chat. If you have any questions that you think of afterwards that you would like to send to us, you can send them our way via that email address, and we can forward them along to our presenters. Or if there's a way for folks to contact you guys that you'd like to share, we can also share that as well. And Edry, the survey is available after you click that link that is going to lead you to the evaluation survey. And after you fill that out, that's where you will download the certificate of attendance.
Are there examples that people have from the work that you do, and some where this has been important to your work? or where this is actually might have caused more complications.
I also see, Dr. Milstein, that Victoria dropped a question in the chat. You brought up keeping our own views separate from the client's. Do you have any suggestions on how to bring up a spiritual discussion, but still making it work appropriate?
Joe, do you want to grab that one? I mean, I'm happy to also.
Yeah, I think, first and foremost, we can go back thousands of years to, Socrates' dictum to know thyself, so I think it's important, I think, first and foremost, you know, to be aware, of, our own journeys, in pursuit of sacredness and meaning, as human beings, right? And to be able to, to have awareness about how spirituality or faith may shape and impact, our journeys for joy and for pain, right? And then out of that awareness, um, we want to be able to kind of hold our own journey towards sacredness and have the capacity to then, curiously and humbly, like really try to understand, our clients, pursuit of sacredness and meaning in their life, right? And hopefully out of that awareness, we can keep our journeys separate from our clients' journeys, or to not kind of overinterpret our own journeys as what our client might be experiencing, in the same way that we would hopefully inquire about other aspects of cultural diversity and identity.
And know that we're there to learn who our client is, who the person is. So that's, it's in that way not a conversation, and certainly not something where we're trying to convince because we're in a process with them.
Yep. Yeah, and I think I'm becoming kind of more and more multicultural orientation framework, and that ideally we want to be like deeply curious, about who our clients are as people, and we want to be deeply curious about their sources of meaning, their sources of pain and suffering, right? And that for many of our clients, we need to expand our frame of reference to attend to spiritual and religious aspects of their lives with humility and compassion and courage.
And to Melissa's point, knowing that they will then live their life not in the clinic. So, where is that community for them? Is that a positive community for them? And encourage, it's giving them the strength to go on their path. So I think that's a piece of it. And again, to Melissa's point, and that's where the healing will happen. That's where the sustained recovery, the healing, the growth will happen.
See a couple of questions in the Q&A feature, one from John. The center where I work in Florida is part of the Soliton Institute network. Curious if you have any connection with their spiritual integration, accreditation, and training.
Yes, I know Steve Deson, and others, really well from Soliton. So we yeah, I'm aware of the different training programs, that Soliton does, and I think just the wonderful resources that all of the Soliton clinics and centers across the country provide to communities. So no, yeah, I think, what we're sort of encouraging clinicians, to really pursue, Soliton has been doing this for decades. Yeah.
All right, well, it looks like we're right almost at the top of the hour. So unfortunately, that's all the time that we're going to have for today. I would like to thank all three of you, Dr. Courier, Dr. Milstein, and Melissa, for this incredible presentation. And I'd also like to thank everyone participating for your thoughtful questions and for your engagement. Again, I have put the link to our evaluation survey in the chat. Please click on that and fill it out so that we can continue to provide great events just like this one. Again, if you need a certificate of attendance for your records, that should be available for download as soon as you complete those evaluation surveys. And if you happen to have any follow-up questions after we end today, please don't hesitate to email us at info@southeastmhttc.org. Thanks everyone again. That is going to conclude today's webinar presentation. Have a great rest of your day.
Thank you.
You.